So, topics of discussion that we're going to talk about today: why do we sit vigil? What does the dying process look like? And what is a vigil volunteer? What do you do as a vigil volunteer? And why are boundaries important? Because that is something that you have to really keep in mind when you are doing vigils. So, why we sit vigil? Our presence communicates to the resident and or family that they're not alone. We don't want them to be alone. I mean, that's part of our slogan here is no one dies alone. So vigil is not about doing, it's about being. And I think we've heard that throughout life, that as a person, it's about being. It's not always about doing. That's how our society puts things out to make you feel like you have to constantly do and go and do. But it's about who you are and what you bring. Being with a dying person is a way to show them support and love when they are in that active dying phase. So she has a quote here. It says, "Death is an integral part of life, as natural and predictable as being born." And that's a statement from Elizabeth Kubler-Ross.
Dying is not a medical event. Dying is a social, communal event. And when we're at the bedside of someone who's dying, it is all about the community, about the togetherness, not about the medical stuff that's going on. But families don't know that. There are new rules for end-of-life care. Taking care of someone in the last months of their life is not like taking care of someone who's going to get better. But most people don't know this. And so my job is to help families understand the new rules. The normal, natural way that a person dies has a process. And that process involves three things: eating, sleeping, and withdrawing from the world around them. The hardest thing for me to get people to understand is that when a person has entered the dying process, it's okay not to eat. Food is what holds us in our body. Food is the anchor that holds us, that gives us grounding. And if the body's preparing to die, it doesn't want the food or the grounding. It's trying to let go. Dying is not painful. Dying does not cause pain. Disease causes pain. So you're going to look at a person's disease history to understand end-of-life pain. We watchers of the dying process are identifying it as it looks painful. Dying itself is not. The person's so removed from their physical body that they don't experience it in the same way that we who have a firm grip on this planet feel it. If pain has been a part of the disease process, and there's a lot of disease out there that has pain, then you are going to treat that pain until the person's last breath. There is no reason today for any person to die in pain. And if someone says to me, we've done everything we can and this person is still in pain, then my answer is, you have not done everything. what we want to give to that person who's leaving us is our presence, is our love, our care, and our concern. And it isn't necessarily the words that we say. It's our being there. The person who's dying, they're reaching a point where words really don't mean anything. It's that you're there. It's the touch, the holding. It's okay to get in bed with your loved one. It's okay to have the dog on the bed. It is that communal companionship, that presence that means more than anything else in the days to hours to even months before death.
Understanding the dying process. So most of you are probably very familiar with what things you might see someone go through as they're going through this process. So just to go over and just review it, I don't want to spend too much time, but if you feel like personally you might want to know more, we can always talk afterwards. That's no problem. Overview of the normal, natural signs of approaching death. So there's going to be physical, emotional, and spiritual, because we're holistic. It's all those parts. The physical, you'll see changes in a person's breathing, their circulation changes, energy level changes. Emotional, they'll be withdrawing more from relationships, from people, not really being social. Restlessness and fear. There may be some fear that they experience. Spiritually, there may be them maybe searching for more meaning or purpose, like what's their purpose? Why were they here? So it may be some of those things that they're kind of going through. And just keeping in mind that everyone that dies, when they're dying, their death is unique. It's not going to be the same as someone over here. Their experience is going to be different. So understanding the dying process. The last hours or when someone is actively dying, resident is usually unconscious and mostly unresponsive. Thing that you'll see significantly as far as changes would be in their physical, mental, and spiritual. So as far as the physical, some of the final days of life, the extremities will get cold, their arms, their legs. You may see some modeling when you're changing positions. It may be, which the modeling is like that bluish purple kind of look because the circulation is changing. It's not as much circulation going to certain parts of the body. There'll be some cyanosis where they may start looking pale, especially around the lips and face, and look more pale and kind of yellow cast. Even on African Americans, you'll kind of still see that. Changes in pulse and blood pressure will also change. I know a lot of times when the hospice nurses come in to see the residents, they will take their blood pressures and check their heart rate, and it'll be lower. So it's just keeping in mind that those are things that could be showing us the signs that they are going into that actively dying stage. During a patient's final days of life, you can see confusion as far as neurological things that they would present. Increased confusion. They may have a sensitivity to light. So we thankfully have those lights that can be dimmed down so that it's not too bright in the room. I always say they kind of have a look on their face or their eyes where they're not tracking you. So it almost looks like a deer in headlights, like they're just kind of staring straight in space almost. So that can change, increase or decrease sensation of touch. So I know most of us like to be touchy-feely, but sometimes it may not be the same type of reception on their part, because that's changing with them. Semi-comatose or comatose state. So it may seem like they're responding to you if you call their name, but it may not really be that. they may be more out of it and go into a comatose state. Metabolic signs and symptoms, there's more fatigue, so they are sleeping more, tired more. Although they could have what we call a surge of energy, where it might be a day or so where they're getting more energy and they're more themselves. They may be more alert, not as unconscious. They may eat a little bit more or eat just in general. Because a lot of times they're getting to the point where they're not eating, so they'll have this surge of energy. And it's like, oh, they ate a full meal, and it's like, yeah, that surge of energy really kicked in for them. Temperature can increase. I was just telling our new caregiver that that's something that a lot of times the hospices will make sure that they have Tylenol suppositories ordered, because if they're to a point where they can't take anything to help keep their temperature at normal, that will be something that they'll order because they can't swallow. But that temperature, it doesn't elevate on everyone, but some people you will see that elevation at the end. And there's other measures that we do to keep that so that they're comfortable. As far as respiratory signs and symptoms, you can hear the secretions. A lot of times people will develop those increased secretions. When they're breathing, they'll have apnea. Their breathing will be shallow. There may be real rapid breathing and then more shallow. And then there may be periods where they just don't take a breath at all, which is the apnea. And they call that the Cheyne-Stokes breathing. You may see them panting, or they're breathing more through their mouth. Like it's just almost like they're blowing or something out of their mouth. Urinary signs, there will be decreased urinary output. Their urine can be very dark and concentrated. They may be incontinent at that point. A lot of times the hospices will have Foley bags, so you can see that it's decreased urine output and how dark it can be. As far as their gastrointestinal, their GI, there's changes in the oral intake. They're not able to. So first of all, they don't really have the appetite that they once had. That changes. There may be nausea, there may be vomiting, could be some constipation, diarrhea, but they're not taking in as much as they once did. We see a lot of changes. The caregivers will say, well, I'm noticing that they're not able to swallow and suck through a straw like they once did. So all of that starts to change as things start to shut down. Agitation, which is something that we really look to make sure that we monitor and let the hospices know about. This can occur at any time during the dying process. It doesn't have to just be when they're actively dying. That it can be a result of confusion and delirium. When they first are admitted, I have to do a questionnaire to determine and score them to see, based on their background, if they're more likely to have terminal agitation as they go through this process. So it could be physical, verbal, or non-aggressive behaviors. It could be them hiding or having hiding or hoarding behaviors. If they're up and still walking around before they start to be actively dying, they could just be pacing. I remember one gentleman, he had agitation so bad. He was just pacing his room constantly. He was putting clothes on top of clothes. He just could not be still. He just was all over the place. And then this says inappropriate dressing. So, yeah. So all of that can let you know that there may be some degree of agitation going on. Terminal agitation, this is usually seen in the imminently dying phases. Non-purposeful motor activity. So they're constantly moving. Just they can't be still or relax. Inability to concentrate or relax. There's disturbances of sleep or rest patterns. So if they sleep, it might be like a baby where they just sleep for 10 or 15 seconds or minutes and then they're up and at it again. It can turn into progressive agitation, which a lot of times that means whatever medications they may have been prescribed, it may need to be adjusted, or they might have to try something different. The definition here says a vigil volunteer provides that calm and compassionate presence to residents during their final hours or days, ensuring they do not die alone. Volunteers offer companionship by sitting with the residents, talking to them. Michelle, you mentioned that, reading, singing, holding their hand. Now, I don't think anybody would want to hear me sing, but, oh no. But I can do the other stuff. So it could be any of these things. Like you said, even playing some music. I mean, we all have access to our phones, and if it's a type of music that you know that person enjoys, I don't think that's probably a good thing for them. Helping with small requests to provide that comfort and support to them. Their role your role as a vigil volunteer extends to providing emotional support to the families. Some of our residents don't have family members that come to visit them. We are their family. So if there are family members here, I think it's okay to include them in it and be a presence for them as well. Offering them a needed break. Maybe they want to go out and get something to eat. Giving them that reassurance that it's okay to leave. I'll be here until you come back, just so they know, okay, it's okay. And that's a way to provide that presence to them. Definition of a vigil volunteer. So being present during the active dying phase, and then being trained to support the patients, the residents, families, and even our caregivers. Some of our caregivers, they get so close, and it's hard not to. They get really close to the residents, especially if they've been here for 6 months or more. I talk about Helen all the time. For those who were here last year when Helen was a resident, we all got attached to her. Like, that was without any say. We were attached to her. So when she transitioned and when she, was no longer here with us, that was different for us. It was different. And I think being able to talk to each other, but as a vigil volunteer, I think that's totally appropriate to check on the caregivers, see how they're doing, letting them know that you're here for them too. Importance of the vigil volunteer: you provide comfort, dignity, and companionship for the resident, restoring humanity to them, providing them comfort. You can serve as an advocate. If you're sitting there and you see something is changed or different with them, notifying the caregiver, notifying me, the house manager, or Holly, who's our executive director, say something doesn't seem quite right, or maybe we should let hospice know. Like, you're sitting with them, you will notice if something is different, and preventing that isolation so that person is not isolated from the world or from other things. For the family and caregivers, offering them the respite, like I mentioned earlier, if they need to go home and get cleaned up or get something to eat, because they have to take care of themselves too. Reducing their anxiety, providing support to them, and this all facilitates a peaceful transition as they're dealing with their own set of emotions as to what they're seeing, what they're going through. Some of these family members have never had a person died close to them, so helping them through this process. And for you as the vigil volunteer, spiritual practice, offering a sense of purpose and providing insight. When we get admissions, there's always a preference sheet that we have the resident and or the family member fill out, and it has things like basic things like what's your preferred name, what do you be preferred to be called, foods that you like or dislike, just different things, music that you enjoy, TV shows that you like. So you can always find that information in the binder that's in the volunteer area right above the cabinet where you all get your badges. So if you're coming to sit vigil with someone, that might be something you want to just quick look over and see if they have a certain type of music that they like, or a TV show. Maybe I would think they would still hear it, because hearing is the last sense to go. It might be something. Now, if it were me, Golden Girls all day long. So just so all of you know, Golden Girls, put them on. Love those girls. So what vigil volunteers do: offer presence, sit quietly, listen. It may be you listening to their family members if they're present, reading softly, holding a hand. I think somebody mentioned that earlier. Supporting loved ones enriches the life of the resident, of their loved ones. Saying goodbye to a friend. It might be that they need to have a phone call. Like if I think Stacia just did this with the recent resident. Her daughter lived in Virginia, so she wasn't able to be here, but she took the phone and put it on speakerphone, and this lady was actively dying. She couldn't respond, but she let the daughter talk, and she could hear her voice. So those are things that you all can do as vigil volunteers. There are some things that we would not recommend that you do. If it's something in this category, it would probably be you telling, like you could put the call button on and let the caregiver know. And if it's something that exceeds what the caregiver can do, it might be a need for hospice to be called and notified. So some things would be definitely like any medical care, so not giving any type of medications. Even the repositioning, if you see that the person looks uncomfortable and maybe needs to be repositioned, it's at that point that I would probably say just let the caregiver on shift know, so that they can assist in doing that. Not providing any counseling. The position that you would be in as a vigil volunteer, there's set people that could help counsel the family members per se. It would be social workers or chaplains that are already involved in their care, not intervening in any clinical issues, like they've already had. Hospice is managing their care. They have a set care plan of how they're doing things. We're here as caregivers and house manager to implement those things, but they're still managing and making the decisions. Prayer, unless it's asked by a loved one or the resident. So we want to be respectful that there's people from different backgrounds. There's some people that don't have that background, so they may not want that. So just keeping that in mind. Helpful versus unhelpful phrases, and you're probably all familiar with this. So some helpful things that you could say to someone: I'm here with you. You're not alone. It's okay to rest. And silence. Just being there. Maybe a gentle touch, not like that, but just a gentle stroke. Most times we don't set up the vigil volunteers. If we see that family members are here and they come regularly every day, we wouldn't do that. I think this is more for those residents who maybe have limited family members or no family members that come, that need somebody during that time. Because like I said, we are their family. So, and we get a lot of older residents that maybe their spouse was not able to care for them at the end of life. So if their spouse can't give them that care, they may not be able to come here and visit on a regular basis. So to have someone sit vigil with that loved one would probably mean the world to them. But if it's something that they feel uncomfortable with, definitely we wouldn't. Yeah. Anything else?
Are vigils 24/7?
So typically, I think the way Demi has been doing it, she'll put it on there for like morning through late evening, because most volunteers are not able to come and sit overnight or don't want to, which I get, you know. We haven't really met too many volunteers that are willing to come in 11 to 7 or, you know, during that time frame. So it usually is all day into the evening. Some of you might be able, because I'm usually gone by 4:35, so I don't know. I think into the evening, like maybe 8 or 9.
8 a.m. to midnight.
Midnight. So that's usually when it cuts off. And most volunteers, I think, do it more so day and evening. I think there's just a few that might stay later.
12,
Okay.
10
PM to midnight.
I have done that
Okay.
a handful of times.
And it helps the caregivers, because especially at night when there's only one caregiver for 6 residents, but at night there's no administrators here. There's no volunteers coming in to do different things. So it's literally just that person and the residents. So it kind of helps the caregiver to know, okay, someone's in there with this person, and I don't have to, like, especially if I'm trying to see about 5 other people. So yeah, that's a great help for everyone. Yeah. Yes, ma'am.
I think you were asking maybe about if you come in for vigil and family here. Is that what you were asking? It's a great opportunity to ask the family to maybe share some of their
That's
favorite
good.
memories.
That's
It's
good.
grueling to sit at the bedside of someone, and they love to share. Also, you can really bless them if you've had interactions with their loved one
Sharing
and have
stories.
something to share of what you appreciated about that resident, or like a little funny story of your interactions.
That's good.
You know, bring them a cup of coffee if they want, you know, just whatever. That can really lighten their day and help them in their grief time.
I agree. That's good.
And it doesn't take long, or
that's
give them a
another-
break, some of the other things you said, but
No, I think
those
that's great.
interactions are really meaningful for both of you, really.
That's another way of being present, I think. Helping the family with their needs. And if they're fine with it, you come in and sharing, and that's totally fine. And it might be at that point, I think we talked about it earlier, where you can offer, I'll be here if you want to go out to get something to eat, you know, so.
So you've been asking them how you can help them, if there's anything that you could get them that they need, just asking straight up too.
Yeah. I like what you said, Gail, about sharing stories that you maybe have had, your experience with that person. That can bring them a lot of joy, I'm sure. Anything else? Okay. It's been a pleasure. Thank you.